Okay, thank you everyone so much for joining today's session. It's a pleasure to have you here today. So I think the rest will just join in as we continue due to time. And it's a great privilege today to have one very passionate speaker, and that is Dr. Jimmy Poloti. She's really passionate from the discussions that you have had, especially about AMR, and what we can do to really try and mitigate this pandemic. So Jimmy is a medical doctor. She's based in South Africa, and she's currently working at a hospital in Switzerland, I think in South Africa. Maybe Jimmy, you can correct me if I'm wrong. And she is also doing a master's in public health from Imperial College London. So I've engaged with Jimmy. We've had some discussions, and she's really passionate about how we can try and mitigate AMR, given her vast experience and what she has witnessed in the clinical setting. So Jimmy, it's a great pleasure to have you today and have you speak to the participants. And we hope that this session will really be mind-opening to them, and at least they will learn a lot from the session. And thank you so much for availing your time, and also for taking quite a lot of time in preparing for this session. We don't take it for granted, and we really do appreciate. Thank you so much. And over to you, Jim. Welcome.
Thank you so much, Daniel, for that introduction. So good afternoon, good evening, good day, everyone, depending on where in the world you're joining us from. So as Daniel mentioned, my name is Jimmy Poloti. I'm a medical doctor from South Africa. I'm currently working for the South African Military Health Services, completing my community service medical year. But as Daniel said, I am very passionate about antimicrobial stewardship and antimicrobial resistance. And it's really an honor to be with everyone tonight. Thank you so much for taking out the time to be here this evening. And thank you so much to the Students Against Superbugs team for inviting me to be a speaker as part of the Antimicrobial Resistance Ambassadors Program for young people in Africa. And the webinar this evening is titled Antimicrobial Resistance, a focus on the human health realm. And the aim for this presentation is really to educate our participants on how patients and healthcare providers contribute to the spread of antimicrobial resistance. And we also want to provide an understanding of how infectious diseases actually contribute to the spread of antimicrobial resistance, whilst also discussing the possibility of an individual being infected with drug-resistant pathogens. And ultimately, I would like for this webinar and its content to further emphasize the need to champion for antimicrobial stewardship, both at the community and hospital level. So thank you again to all the participants who have joined this evening and that are embarking on this program to champion for antimicrobial resistance awareness and stewardship. So this is just a bit of an outline of what we will be talking about in today's webinar, just so that we're all aware of the content we'll be discussing and the order in which we will be doing so. I always find it quite useful to define antimicrobial resistance so that we're all on a similar page when I refer to the term. And just note that I might use antimicrobial and antibiotic interchangeably. I mean the same thing when I say those two words. After which I think it would be quite useful to discuss a bit of epidemiology and prevalence of antimicrobial resistance, just to get an idea of how big of a global health concern AMR actually is. And again, if I use the term AMR, I'm referring to antimicrobial resistance. After this, I would just like to take a brief moment to classify antimicrobial resistance according to its mechanisms of development, before going on to discuss key factors that contribute to AMR and how it is accelerated through certain factors and the spread of infectious diseases. And since the focus of this webinar is really on the human health realm, I'd like to spend a greater amount of time discussing various patient and healthcare provider behaviors that contribute to AMR. Then we will look at how antimicrobial resistance can actually derail other treatment intervention in the healthcare of patients. And then we will look at other implications that AMR have within the hospital setting, before briefly looking at a description and introduction to antimicrobial stewardship programs, with emphasis on the use and development of such programs in the communities and hospitals. And hopefully by the end of this webinar, you will feel the need to champion and really go out and advocate for good antimicrobial stewardship programs and resistance awareness. So firstly, what is antimicrobial resistance? Well, there are several definitions that exist, and they all have slight variations. But the one that I like best, and that I shall use for the purpose of this presentation, is this one on the slide depicted here. And it comes from a textbook by Kahn and Rye on antibiotic resistance, whereby antimicrobial resistance is defined as the resistance of microorganisms to an antimicrobial agent to which they were at first sensitive. So why I like this definition is because we must remember that many organisms are going to be inherently resistant to certain pharmacological agents. And that's simply due to the mechanism of action or the spectrum of coverage of that particular antimicrobial. And this is not necessarily the antimicrobial resistance that we're concerned about or referring to in this instance. We know that certain antimicrobial agents do not work, have not worked, and will not work for certain pathogens. And this is not really the same as antimicrobial resistance that we're talking about. And I really want to emphasize this difference, and we will expand on it a bit more when we go into the classification of antimicrobial resistance. So what I like about this definition is that it includes the key phrase to which they were at first sensitive. And I think something that needs to be emphasized here is the fact that antimicrobial resistance is not a new concept. As early as the year 1945, Sir Alexander Fleming, who we know discovered penicillin, had conducted research that led him to warn in an interview with the New York Times that the inappropriate use of penicillin could lead to the selection of resistant mutant forms of Staphylococcus aureus that could cause more serious infections in the host or in other people that the host was in contact with. So, if this is a problem that was already identified in 1945, why is antimicrobial resistance such a giant problem now? And why have we not been doing more to halt its progression over the past 70 plus years? So if we take a look at a bit of the epidemiology of antimicrobial resistance, we know that the World Health Organization declared AMR one of the top 10 global public health threats to humanity. And to further reiterate the importance of AMR, we have a peer-reviewed paper published in The Lancet that demonstrated the true global impact of antimicrobial resistance when it revealed that at least 1.27 million deaths worldwide were attributed directly to antimicrobial resistance in the year 2019. And I think the greatest tragedy is that 1 in 5 of these deaths actually occurred in children under the age of 5 years. Now, interestingly enough, although they found that both low and high income countries have significant burdens of antimicrobial resistance, this paper showed that the highest burden of antimicrobial resistance was actually in sub-Saharan Africa, which was interesting because the rates of antibiotic use weren't necessarily the highest in sub-Saharan Africa. And another concerning factor is that the growth of resistance is not matched by the development of novel pharmaceuticals. So really, the antibiotic era, or the golden age of antibiotics, really peaked in the 1950s, where we had a lot of new antimicrobials being developed and discovered. But since then, in modern day times, there's been relatively minimal novel therapeutic antimicrobials in the pipeline in development to target these pathogens that we're concerned about. And the growth of resistance is much greater than our rate of developing new drugs. So if we talk about the classification of antimicrobial resistance, again, there's many ways in which we can classify antimicrobial resistance, but I like to look at it as natural versus acquired. And natural resistance can be further divided into intrinsic or induced. So intrinsic resistance, as part of the natural resistance, refers to a trait that is universally present within a species of bacteria and is always expressed, that confers resistance to certain antimicrobials. So this resistance is independent of any previous antibiotic exposure and is not related to horizontal gene transfer. So this is that type of resistance that I was referring to earlier in the presentation, the kind where we have an organism that is intrinsically naturally resistant to a certain antimicrobial, whereby that medication has never and will never be effective against that organism. Then we come to induced resistance, which is what we are perhaps far more concerned about. And this refers to resistance that develops due to the expression of resistant genes that naturally occur in that bacteria, but are only expressed to levels sufficient enough to result in antimicrobial resistance after exposure to that antimicrobial. So these are bacteria that are sensitive or susceptible to the antimicrobial, but they naturally possess the genes to become resistant to that antimicrobial. And then after possibly repeated exposure to that antimicrobial, that's where those genes are expressed at a level that makes that bacteria become resistant. And then we come to acquired resistance, which is the acquisition of genetic material by a bacteria that will confer resistance to an antimicrobial. And this genetic material is acquired through the process of horizontal gene transfer or through mutations of the bacteria's own chromosomal DNA. And interestingly enough, acquisition can be temporary or permanent. And these mutations usually occur in those genes of the bacteria that encode for drug targets, drug transporters, regulators of drug transporters, and antibiotic modifying enzymes. And we'll come a bit more into detail of how that mechanisms of AMR actually come about. So here I've just included a diagram, and these are the four main categories of antimicrobial resistance mechanisms. So we've spoken about how the bacteria or organism can come to either naturally obtain or acquire the genetic material that's going to make it resistant, but how is it actually resistant to this antimicrobial? And these are the four main categories here. So this mutation seen in the organism is going to result in one of these four things: either active drug efflux, limited drug uptake, modification of the drug target, or inactivation of the drug. So when we talk about active drug efflux, this is where the bacteria or organism has either developed or acquired the ability to actually pump the drug out of the cell. And therefore, you're never going to get that active drug actually working in the cell enough to destroy the bacteria, because it is being pumped out of that bacteria. And therefore, it's never going to reach the levels necessary to actually result in destruction of that bacteria. The same with limiting of the drug uptake. If you cannot uptake a drug into the bacteria, it's never going to reach the therapeutic level that it needs to destroy that bacteria effectively or sufficiently. And then modifying the drug target means that the drug is actually not going to bind to the target on the bacteria, and therefore it's also not going to exert its effects. And inactivating the drug, I think, is quite self-explanatory. The drug is simply made inactive and unable to work. So now we need to look at what are the key contributors to antimicrobial resistance, because this is where we want to intervene. If we know what contributes to the development of antimicrobial resistance, we can know where we can intervene. So according to the World Health Organization, the main drivers of antimicrobial resistance are the misuse and overuse of antimicrobials, lack of access to clean water, sanitation and hygiene, and that's for both humans and animals, poor infection and disease prevention and control in healthcare facilities and farms are also included, and poor access to quality, affordable medications, vaccinations and diagnostics, and then lack of awareness and knowledge, and lack of enforcement of legislation. For the purpose of this webinar, we really want to focus on, like we said, the human health realm. So what is it that healthcare providers and patients are doing that are contributing to antimicrobial resistance? So this is just kind of a diagrammatic view of the contributing factors to the development and spread of antibiotic resistance. And there's quite a few factors here, and we're not going to go through each of them for the sake of time, but I think it just really highlights the multifaceted and complex integration of multiple factors that are involved in the development of antibiotic resistance. And it emphasizes that it's not one factor. And I think that shows that our interventions to mitigate antimicrobial resistance also cannot be one-dimensional. We need to think multi-sectoral and multi-dimensional as well. Another key factor is that resistance promotes resistance. So even though many mutations conferring antimicrobial resistance do so at the cost of the organism, what do I mean by that? It means that there are many mutations that a bacteria can actually develop or acquire that will make it resistant to the antimicrobial, but will also make it less pathogenic. So for example, there are some antimicrobial resistance genes that can be acquired that will make the bacteria divide more slowly or make it less pathogenic. And therefore, we say that that mutation is created at the cost to the organism. And then that means that that organism is not very likely to spread, or it's likely to die off. However, when it becomes concerning is that resistant strains of bacteria are often preferentially selected for. And this is because ineffective antimicrobial therapy against resistant organisms increases the survival and transmission of these organisms compared to drug-susceptible organisms. So what do I mean by this? What I mean is that under the selective pressure of antibiotics, bacteria that are susceptible to those antibiotics are going to be killed or inhibited, whilst the other resistant bacteria, the one that we're concerned about, that are either naturally, like we described, resistant or have acquired an antibiotic resistance, they have a greater chance of survival and a greater chance of multiplication. And with this greater chance of survival and multiplication comes the increased chance of spread and propagation across the globe. And this further perpetuates the burden of antimicrobial resistance. So this is how the development of antimicrobial resistance pathogens actually further exacerbates or perpetuates more antimicrobial resistant pathogens developing, because we continue to use the antimicrobials and we continue to destroy the susceptible bacteria, but we're not destroying the resistant bacteria. And therefore, we're creating an environment that basically selects or is in favor of the survival of those resistant bacteria. And that's something that's really concerning. So what are the healthcare providers' behaviors that contribute to antimicrobial resistance? So we've just spoken about how infection and spread of infection is going to make antimicrobial resistance worse, because the more spread of infection you have, the more opportunity you've provided that bacteria to multiply. So even if that bacteria wasn't originally resistant, if measures are not put into place to prevent the spread of infections, the more infections that we have spreading, the more chances that bacteria has to acquire mutations to make it resistant. On top of that, you can have the spread of an already resistant organism, which of course you don't want. So we want there to be effective prevention of infection and the spread of pathogens, because not only will that stop the spread of the pathogens that are already resistant, but it also limits the chance of the susceptible organisms spreading and acquiring further mutations that would make them then resistant. So what are healthcare providers doing or not doing that's contributing to antimicrobial resistance? We really need to look at what are we doing or not doing to prevent the spread of infection. So when healthcare providers don't adhere to infection prevention and control measures, or we do not educate our patients on the need for up-to-date vaccinations, or when we fail to educate our patients on infection prevention and control, or we ourselves do not stay informed or up-to-date on current outbreaks, then we are undoubtedly contributing to antimicrobial resistance, because we are not aiding the prevention of that infection. We're not aiding the prevention of infection spread, essentially. Also, when healthcare providers fail to notify the laboratory or receiving facilities of a patient that has a resistant pathogen, then we don't have the appropriate or adequate infection prevention control measures put in place. Maybe that patient is not transported appropriately, individuals do not wear the correct PPE, or we don't have that individual being placed in the correct isolation ward. Again, that's going to contribute to that spread of that resistant pathogen. And failing to inform your patient or the family members of patients that they have an antibiotic resistant infection is also problematic, because whilst we spoke about now patients with antimicrobial resistant organisms being transferred to different facilities, you're not always going to have someone with a resistant pathogen being admitted to hospital. Sometimes you send that patient home, back to a family who may have different comorbidities to that patient, who may have different disease profile and may be more susceptible to adverse events related to that resistant organism, and maybe they won't be as resilient or have as much reserve to actually combat that resistant organism. And if you are living within close contact with these individuals and you have not warned your patient that they have this resistant organism, then that can also propagate and promote spread. And then failing to report cases where applicable and submit the appropriate resistant isolates to the relevant health department. And something I really want to emphasize and maybe spend a bit more time on under the healthcare providers' behaviors that contribute to antimicrobial resistance is inappropriate antibiotic prescribing. So we see it often where healthcare providers and clinicians fail to follow clinical and treatment guidelines. They prescribe repeated courses of antibiotics, and they do not consider whether there's an alternative organism or diagnosis in their patient who was not responding to the antibiotic. And I've seen it just anecdotally in my own practice area, where we've had patients who've had TB who have been treated with multiple courses of antibiotics, often broad spectrum like Augmentin, who do not get better, and they come back for 4 or 5 courses, and the healthcare provider has not thought that there's probably something else going on here. This patient is not responding to the antibiotics. We've got to think of something else. And not performing appropriate diagnostic tests, to guide antibiotic drug choice, dose, and duration. Remember, oftentimes we start off with broad spectrum antibiotics, but ideally we really want to be tapering these down to narrow spectrum antibiotics, and often that's not done. Or often the susceptibility testing is conducted and no one has bothered to check the results and adjust the antibiotics appropriately according to that result. And then we've wasted laboratory resources to get a result that we don't actually act upon, which is also a problem in itself. So inappropriate antimicrobial prescribing, why do healthcare providers do it? Why do we prescribe antimicrobials inappropriately, even if we know that it is inappropriate? And I think something that is worth noting here is that patient and healthcare provider interactions are complex. And there are articles upon articles upon articles available on the internet describing the different reasons why antimicrobials are prescribed. And the key factors that come up repeatedly are that sometimes there's a lack of knowledge surrounding antibiotic guidelines. Guidelines change, or sometimes someone's been out of an academic setting for a long period of time. They may not be necessarily up to date with these guidelines. And so they don't necessarily have the correct knowledge about when or maybe what antibiotic to prescribe. And then there's, of course, the factor of patient pressure. A lot of the time, or maybe not a lot of the time, but there's certainly instances where patients come to the doctor expecting an antibiotic. And they may put pressure on that healthcare provider to prescribe that antibiotic, even if the healthcare provider knows that it's not appropriate in this clinical case. And patients may feel unsatisfied with the consultation if they leave without an antibiotic. And then sometimes a clinician is uncertain of the actual diagnosis and might just be trying to treat quite broadly. And then there's also the aspect of fatigue and burnout. Often, particularly in primary healthcare settings, we have a physician who is consulting multiple patients in a day. There's very long queues, they're exhausted. And sometimes if that patient is putting that pressure on you and it's a little bit later in the day, often physicians might cave in and prescribe things that they know is not necessarily best practice. And here's just, again, a diagram showing that the decision-making process with regards to whether or not to prescribe antibiotics is complex. It involves environmental and contextual factors, both internal and external factors listed here. And these all work together to influence whether a healthcare provider will actually prescribe an antibiotic, whether they know that it is the correct practice or not. So it's a very complex area, and it's not simply simple and saying that, oh, the clinician or healthcare provider didn't know that it was inappropriate. Oftentimes, I think that's a bit of an oversimplification. And then we can't say that it is entirely the healthcare provider's fault. As I said, antimicrobial resistance is multifactorial. And I think it's important to discuss the patient behaviors that contribute to antimicrobial resistance. So if your patients have poor hand hygiene, or they are avoiding vaccinations that are part of the scheduled recommended vaccinations for your country, this promotes the spread and acquisition of infections. And we've already spoken about how the spread and acquisition of infections propagates antimicrobial resistance. We want to limit the spread of infections, to limit antibiotic use, and limit the mutation that these bacteria actually undergo. And then we also have poor health-seeking behavior. So sometimes individuals fail to recognize the severity of their condition. Sometimes the healthcare facility is inaccessible for a number of reasons. It can be very far. The patient may live in a very rural area. They may not have the financial means to actually visit the healthcare center. And this delayed presentation to healthcare can result in increased transmission of pathogens in the community. For example, we had a patient the other day who had been coughing for 4 months, and we did a gene expert sputum, and it came back that this patient actually had multi-drug resistant TB. Now, we cannot say for sure that he acquired that multi-drug resistant TB 4 months ago, but if he started with the symptoms of TB 4 months ago, it's likely that he's had this infection for a long time. And his delay in the health-seeking behavior has resulted in, we will never be able to quantify, but possibly the spread of that multi-drug resistant TB to other members of the community and the household. So that's also another very important behavior that should not be overlooked. And then the use of antibiotics inappropriately, I'm going to discuss it in a bit more depth on the next slide, but also poor food preparing habits and poor health practices with animals. We must remember that there are bacteria, there are organisms that we can get from poorly prepared food or from close contact with certain animals. And sometimes these organisms can also be resistant. And then acquiring and spreading infection when traveling abroad and acquiring STIs. Many times we have patients presenting to the clinic, they present with an STI, they do not present with their partner. And it's interesting to see, I think it would be interesting to note whether those partners actually ever get tested. And if you have reinfection of these STIs, then that's also just going to propagate and promote resistance as well. So inappropriate antimicrobial usage. So we spoke about the healthcare provider inappropriately prescribing antimicrobials, but how do patients inappropriately use antimicrobials? So sometimes patients feel a lot better after the first few days of treatment, and they don't necessarily know or feel like they need to complete the antimicrobial course. And that's not something we can entirely blame on patients. Healthcare providers, pharmacists, anyone who is prescribing or dispensing medication should reiterate the need to complete the course. And I think many times we actually have stickers on the box to say complete the course, but even with all of this, you're still going to get the select few patients who they feel better, they don't really understand the concept of antimicrobial resistance, and they don't finish the course as prescribed. And then you get patients who there's an old antibiotic lying around in the house, maybe another family member had an antibiotic prescribed that they never took, or maybe the course that they didn't complete. And the family member thinks, well, I'll just take this antibiotic without actually seeking medical treatment first, and that's going to be another thing that just contributes and propagates antimicrobial resistance. And then not taking the correct dose at the correct time. Maybe someone's forgotten to take their medication. And if you have this subtherapeutic level of the antimicrobial in the body, that's going to be a significant contributor to the development of resistance. So now that we've spoken about what the key factors are in terms of the development of antimicrobial resistance, I think it's important to discuss what does this actually mean for healthcare. So it's obvious to say that antimicrobial resistance is going to affect the way that we treat infectious diseases. But what about other medical and surgical treatments? And it's important to note that the development of antimicrobials has actually been attributed to expanding the average human lifespan by 23 years. And antibiotics have also made it possible for us to perform life-preserving surgical procedures, such as open cardiac surgery, neurosurgery, and also provide certain life-threatening treatments, such as chemotherapy. And antimicrobials have allowed us to do this safely or more effectively. Now, what does antimicrobial resistance mean for these medical and surgical treatments that antibiotics have traditionally helped us or enabled us to carry out? Well, in terms of surgical treatments, antibiotics for surgical site infection prevention is actually the mainstay of care. So many procedures require the prophylactic use of antibiotics to prevent surgical site infections, which is actually one of the most commonly acquired hospital infections that is seen globally. And if we have antimicrobial resistance, this can compromise our ability to prevent and treat these surgical site infections. And then in terms of medical treatment, immunocompromised patients are at an increased risk of severe life-threatening infections, and our ability to prevent and treat these safely will also be undoubtedly affected by antimicrobial resistance. So it's not just infectious diseases that we're concerned about, it's also other medical and surgical treatments that are affected by this resistance. And if we look at antimicrobial resistance and the hospitalized patient, we know that hospitalized patients are at an increased risk of acquiring certain resistant pathogens or superbugs. And the problem with this is that hospitalized patients infected with resistant organisms are at an increased risk of morbidity and mortality because these infections can be particularly difficult to treat, and some facilities might not even have the drugs necessary to treat this resistant organism. And then we also have the prospect of prolonged hospital stay. And prolonged hospital stay not only then increases the patient's risk of developing other hospital complications like thromboembolic disease, but it also means that we are now using excess hospital resources to look after that patient. And this leads to increased hospitalization costs. And if the patient is paying out of pocket, this could essentially bankrupt a family. But if the government is paying, it also means that we're having this considerable additional cost to the government that we could have actually avoided if we did not have these resistant pathogens. And then there's also the increased need for surgical intervention. So sometimes the development of these resistant infections in a hospitalized patient actually requires surgical debridement. And we know that surgical interventions bring their own risks and their own contribution to patient morbidity and mortality. So antimicrobial resistance is really, really a problem. And we can see particularly it affects multiple sectors. It affects the patient, it affects the hospital, it affects the economy, and it affects the patient's family as well, particularly if this patient who has now had to stay in hospital for a prolonged period of time is the breadwinner of that family. And now that family does not have someone working, bringing in an income for them. It can be very problematic, and it goes beyond the patient who has got this infectious agent. So now the last bit of our talk is going to really discuss antimicrobial stewardship. And I'm hoping that everyone on this program is really going to become passionate about antimicrobial stewardship, because it really does. It starts with us. Often we have beautiful policies on antimicrobial stewardship. The World Health Organization and Center for Disease Control and Prevention publishes a lot of research and a lot of different strategies, and it's often not implemented. And we need to do that. The people on the ground in the community, we need to be the champions for this change. So if we look at what antimicrobial stewardship actually is, I quite like the CDC's definition, where they say that antibiotic stewardship is the effort to measure and improve how antibiotics are prescribed by clinicians and used by patients. So I like that there's this aspect of measuring, because we need to be able to know what the scale of the issue is in order to improve it. And I like that it includes the clinician aspect and the patient aspect, because it really is, like I said, both parties are involved. And according to the World Health Organization, the Antimicrobial Stewardship Program aims are to optimize the use of antibiotics, promote behavior change in antibiotic prescribing and dispensing, to improve the quality of care and the outcome in our patients, to save on unnecessary healthcare costs, and we spoke about those in the previous slide, to reduce the further emergence, selection, and spread of antimicrobial resistance, and to prolong the lifespan of existing antibiotics. Remember, we said that there's not a lot of novel therapeutics and antibiotics in development or in the pipeline. So we really want to prolong the lifespan of the antimicrobials that we already have so that we do not enter a post-antibiotic era where we have organisms that are completely resistant to everything that you throw at them. And then limit the adverse economic impact of antimicrobial resistance. So like we said, it's not just the patient and the infectious disease that we are concerned about. Antimicrobial resistance affects much more than just the patient. And then also to build the best practices capacity of healthcare professionals regarding the rational use of antibiotics. So antimicrobial stewardship in the hospitals, what does that really look like? So really, when we talk about antimicrobial stewardship, it's where we implement certain strategies or certain behaviors or protocols to prevent device and procedure-related infections, to stop the spread of resistant germs between healthcare facilities, but also within different areas of a single healthcare facility, to contain those emerging threats through early detection and aggressive response to those threats, tracking and improving appropriate antibiotic use. Remember, we said in the CDC definition, we need to measure antimicrobial resistance in order to improve it. And then infection prevention and control in non-hospital settings, such as long-term care facilities. So these are your care facilities, maybe where you have patients. It's not really a hospital, but more like potentially something like an old age home. And what about antimicrobial stewardship in the communities? Because to implement antimicrobial stewardship in the hospital is not enough. The large majority of patients will not actually enter into a district or tertiary healthcare hospital or facility. A large proportion of patients are going to be seen at the primary healthcare facility or within the community. And that's where we need to really focus our antimicrobial stewardship. So we need to prevent infections. We need to screen at-risk groups for things like TB and STIs, and we need to treat them promptly. So remember, I spoke about that gentleman with the multi-drug resistant TB whose diagnosis was delayed by 4 months. That's going to contribute to the spread of that organism. We need to try and find ways to reduce that or prevent that from happening. And improve infection prevention and control so we can encourage safe sex practices, educate on safe handling and preparation of food and good hand hygiene, and encourage and support vaccinations in order to prevent infections and reduce the need for antibiotics. And then one of the biggest ones, improving antibiotic use. Educate, educate, educate. We cannot blame patients, we cannot blame members of the community for taking antibiotics inappropriately if we have not educated them on how to take the antibiotics, and if we have not educated them on the potential adverse effects of not taking that antibiotic appropriately. So this is a document that is actually available freely online. It's quite extensive, so we do not have enough time within this webinar to go through it, but I think it's a really valuable document. Like I said, it is freely available online. You can just type this into Google and it will come up. And it's a nice little booklet on antimicrobial stewardship programs in healthcare facilities in low and middle income countries. And it gives you checklists on what you can actually do to implement certain practices within your area or within your community. So I find this a really nice document. Like I said, a bit too comprehensive to discuss in detail with the time that we have available to us, but it is freely available, open access to everyone. So I would encourage that everyone goes and looks at that. And then just briefly to finish off, I'd just like to talk about things beyond antimicrobial stewardship programs. So the World Health Organization has recognized that there's this need for coordinated action when it comes to antimicrobial resistance. Like we have said multiple times, it's not a one solution or one size fits all. And there's definitely not one area or one sector or one person to blame with the development of antimicrobial resistance. And we really need a One Health approach. We also need further development of funding initiatives, such as the Antimicrobial Resistance Multi-Partner Trust Fund and the Global Antibiotic Research and Development Partnership and the AMR Action Fund. And then I've just listed a few programs and a few, shall I say, organizations and systems that are available globally to try and mitigate and reduce antimicrobial resistance. So we have the Global Action Plan on Antimicrobial Resistance. There's World Antimicrobial Awareness Week, the Global Antimicrobial Resistance and Use Surveillance System, the Global Research and Development Priority Setting for AMR, and the Global Antibiotic Research and Development Partnership. So we can see that there's a lot going on, but like I said, we need to make changes on the ground, in our own communities, in our own practices, in order for all of this to be effective. So just in closing, some concluding thoughts. Antimicrobial resistance is complex. I think this is something that we've definitely covered in this webinar. It's multifaceted and it's a global health crisis. No area on the world is free or exempt from this problem. And it requires integrated, coordinated, and sustained efforts to affect change. And I think that's a very important or key word there, sustained efforts. This is not something that we're going to fix overnight. It's not something that one person is going to fix. And we need championing for antimicrobial stewardship to begin at the community level, and hopefully engagement and support from higher levels of government and healthcare policymakers will follow. But there needs to be this integration and there needs to be buy-in from every single level. And with that, I want to say thank you so much for being here and for listening and for providing me with this opportunity to speak on antimicrobial resistance. I hope that this talk has brought about maybe some new concepts or highlighted some concepts you might have already known about. And I really hope that it's brought home the idea that antimicrobial resistance is a global problem, but we need to think global and act local when it comes to the solutions. And I hope I've provided you with some inspiration and some insights. And yeah, thank you very much.
Wow. Thank you so much, Dr. Jimmy, for that. I think it was really eye-opening, and I think you really did a lot of research and a lot of reading and a lot of trying to compile a lot of things together. And I think it was really also very fascinating for me, a well-prepared presentation. And thank you so much for looking at the different aspects and going beyond, what is really discussed conventionally in most settings. And I really appreciate that you really took your time, and I'm sure we will all vote to have you again for another session. So thank you so much, and we really appreciate for that very wonderful discussion. And I would just like to reiterate, as Dr. Jamie has said, we think global but act local, right? So let's, I think from today's discussion, each of us can pick somewhere, just one thing that you think you can do to be an antimicrobial stewardship advocate. And I think we'll also love to hear your views in the different platforms that use. What single action or what intervention would you like to, engage in or push forward if as an antimicrobial stewardship agent? Just one for now. So I'll go over to the questions, and I think we had a few questions from some of the members. And the first question was from Faithful, and Faithful was asking, compared to homes, isn't the hospital a safer place to keep the patients with antimicrobial resistance due to the spread of the pandemic. Yeah, so maybe Dr. Jimmy, you can maybe comment on that.
Right. So personally, I would say that if you can, at home is always safer for the patient. So you've got to weigh that up. So when we say, is it safer for this patient with a resistant pathogen to be in the hospital or to be at home? I think the answer is it depends. So if this patient with the resistant pathogen is in a home in which they can isolate or in which they can be separate from other members of the household, and they are stable enough to be at home and they can take oral treatment for this resistant pathogen, then I would say that it is safer for that patient to be at home, simply because then you are not exposing them to even more resistant pathogens. And to have two or more resistant pathogens infecting one person, that's going to be a nightmare to treat. And that's also going to contribute to antimicrobial resistance even more. So that's one thing. However, I think that, so that's why you wouldn't want the patient to be in hospital. That's why you'd prefer them to be at home. But then, like you said, it is also very difficult because now you might have a patient who lives in a one-bedroom house with multiple had this resistant organism. So I think it's really something that you need to take on an individual basis. I think there's no one size fits all again for that. I think you need to weigh up whether the patient is able to isolate or not. But again, I don't think that the inability of a patient to isolate from family members is going to be enough to justify them being in hospital, especially if the hospital is very full or overwhelmed or overburdened. So yeah, I think the conclusion in that is that it would definitely need to be taken on an individual basis and based on the clinical status of the patient and their ability to isolate at home or not. But to summarize, I would say for the patient, it would probably be safer for them to be at home because they wouldn't have the risk of acquiring a second resistant infection. I hope I answered the question.
Yeah, Faithful, are you satisfied with the response? Maybe as you can type in the chat box as we go to the next question. This was from Kushinga. And so Kushinga was saying antimicrobial stewardship is almost always in conflict with empirical therapy while awaiting sensitivity results from the laboratory. Maybe Dr. Jimmy will just explain a bit about empiric therapy. So for those who might not be aware of the term, are there any approved point of care devices that can distinguish between bacterial infections from viral infections and other clinical conditions so as to limit unwarranted empiric treatment? Thank you. Over to you, Dr.
Right.
Jimmy.
Great, so that's an excellent question. I don't actually know of any points of care testing that is available to differentiate bacteria from viruses. I am almost 99% sure that it does not exist yet, but that would be an excellent tool to have to distinguish bacterial versus viral infections. Usually clinicians work off of certain clinical criteria that are more suggestive of a bacterial infection or more suggestive of a viral infection. There's several criteria that have been published, like the fever pain criteria, that help you to kind of differentiate between whether the patient might have a sore throat from a bacteria or from a virus. But again, none of that is absolute. So even if the patient meets the criteria and it's more leaning more towards being a bacterial kind of picture, it's not to say that that patient definitely has a bacterial infection. So nothing is ever absolute, nothing is ever 100%. And point of care testing, I don't think, as far as I'm aware, is not available to distinguish between the two. So the decision to prescribe antibiotics is often based on clinical judgment and maybe the use of some criteria that have been developed to try and differentiate between a bacterial and viral infection. But even those are not, like I said, 100%. So sometimes when we talk about empiric antimicrobial therapy, we have broad spectrum antibiotics and we have narrow spectrum antibiotics. And broad spectrum antibiotics, things like your augmentin, penicillin, they cover a wider range of microorganisms, whereas your narrow spectrum, as the word implies, are going to cover a narrower amount of organisms. And the reason why we use empiric therapy in the beginning, or why we use empiric therapy in maybe primary healthcare, is because I don't think we have the resources or capability to send off cultures or swabs for every single person that comes in that we suspect might have a bacterial infection. It wouldn't be economically, it wouldn't be economical, I don't think. So we give the broad spectrum antibiotics while we're awaiting further sensitivity, or if we don't plan on doing sensitivity. So if you go to the GP and he thinks you have a bacterial throat infection, he might give you an antibiotic, but he's not going to culture your throat or do any further tests. And he or she knows that microbial agent will cover the majority of the common infections. So I think, and even the lab testing has its own problems, because we can start people on broad spectrum antibiotics, we can do the testing, but sometimes lab results take very long to get back to us. Sometimes the specimen isn't adequate. So there's a whole bunch of factors that can also affect that. So yeah, I hope that has answered the question on empirical antibiotic treatment and the point of care testing to differentiate between the two.
Yeah, thank you so much, Dr. Jimmy, for that. Obed, Anita, and Mabla, I can see your hands, so we'll come to you once we address just a few in the chat box. Then we come to you, then we'll go back to the chat box. Quite some good reaction, Dr. Jimmy. So the other question is from Clinton. Clinton, first thanks you for the wonderful presentation, and then he asks, let's say you have faced such a situation in which a patient wanted and is still insisting on having an antibiotic, though you know there is no need for the case in question. How can you solve this in a way that he or she will not go back to disturb? And let me also add something to the question, given our setting. So for most African countries, this may happen especially in the community pharmacies, not just in the clinical setting. And for example, what happens is that, for example, in Kenya, we have a lot of unregistered community pharmacies, which are not run by professionals. So you find that a patient may come to you as a professional, a health professional, and they really pressure about getting that antibiotic. But then there's the issue of, if you don't give them that antibiotic, they may just go to the next, the next shop or the next outlet, their drug outlet selling the antibiotics. And maybe they even get some, they're given combinations which can react and everything, And in case you want to maintain, for doctors who run private clinics, and they want to maintain their credibility to their patients, how then do we address all this? I know I'm trying to intertwine it with some ethical issues. Yeah, so over to you, Dr. Jim.
Yes, thank you, Daniel. Yeah, that's a very, very interesting question. And it is something that I think is very important. And it's something that I think I touched on in the presentation, is that this interaction with not even just a doctor, but a pharmacist, any professional who prescribes or dispenses antimicrobials, nurses, healthcare providers, pharmacists, there is this complex interaction. And it's like you've said, Daniel, where what if I do not give this patient and then they go and get it from somewhere else, or they no longer want to come see me as their doctor because I do not give them what they want. And that's what our healthcare system is facing. And it is a problem because it is almost an idea that is within the community that if they feel sick, they must get an antibiotic. And sometimes they're presenting with something that you would never prescribe an antibiotic for, but it's almost because that's what they know and that's what they've heard, that's what they come and they ask for. So again, I think it's very difficult, but how I would do it, or how I have done it within my practice, is I try to understand, why do they want an antibiotic? Where does their understanding come from that an antibiotic will be what will help them? Maybe that's something that they heard from a family member, maybe it's something from the community, just so you can try and understand where their concept of the antibiotic being the thing that they need comes from. And obviously not to do this in an aggressive or patronizing way, but just to understand why the patient wants the antibiotic. And then I always explain to them why I don't think that it is necessary in this instance. Again, difficult conversation to have, but I feel what helps is when I explain to them that if you take too many antibiotics and everyone takes too many antibiotics, the germs are no longer going to respond to these antibiotics, and then we're going to have very little or nothing to treat you with. And more often than not, the patient, in my anecdotal experience, has taken the time to sit and think, and then they say, okay, I actually didn't know that. And some of them, not all of them, have said, okay, I understand, I won't take the antibiotic. But there are going to be the patients that even after you've taken the time to understand why they want the antibiotic, taken the time to explain the risks and how it contributes to antimicrobial resistance, and now you've got a long line of patients waiting for more scripts or waiting to see you because you've really taken your time with this patient, and they're still insisting on antimicrobials, then that really needs to come down to your own judgment. Yes, there is the risk that you run where if you say, no, I'm not going to prescribe this, that they will not come back to you, or that they will just go and get it from somewhere else. But I believe that the only way we're ever going to make a change is by making small changes. We're not going to be able to instill this idea in the general community about antimicrobial resistance overnight. It's something that needs campaigning. It's something that needs more media attention, needs more advocacy, needs more coverage in the community, so that the community members are aware that this is actually a global problem. This is actually something that could kill me, you know? So I think if the communities were made more aware of that and they were more in tune with the actual threat, then we would start to see less and less and less asking for antimicrobials in that sense. So very difficult situations. Again, I'm going to say that it's going to come down to the individual situation, but yeah, like I said, it is kind of a culture, and it's a global culture of wanting antibiotics that we're going to need to change, and that change is only going to come about through us educating them, and it will take time.
Thank you so much, Dr. Jimmy, for that. Yeah, I really agree, and and you've also spoken about medical providers being being the stewards, or being the agents of communication, and this can really help patients know more about it, and trying to simplify it as much as possible in a way that they understand why they don't need the antibiotics, and why these antibiotics, even though they perceive them to be helpful, could also be harmful to them and to the society at large. And this doesn't really just apply to healthcare professionals. As you've said, yeah, it's gradual by gradual, just a step at a time. Now that we have received this knowledge, it's upon us now to cascade it to different people. And also, just to appreciate that we also have some students who are not in the healthcare realm. So I think we'll share the presentation, we'll share the recording, we'll share about the whole of the toolkit on antimicrobial stewardship, so that you're also able to just go through it slowly by slowly, and you're able to appreciate the concept and what you in your individual capacity can do about that. Before you go to the next question, I will go to Anita. There's this issue of diagnostics. I think that had been shared, and I think that's why we are here. I'm sure just through research, we can always come up with ideas, and maybe that's something that you can focus on. Maybe someone in the group, and see how they can, how you could maybe engage as a group and see how you can read more on what concerns the rapid diagnostic kits, and not just the rapid kits. The issue also of access, because I know there is a lot being done on the same. How then can we ensure that they're accessible in these, in low and middle income countries? So I would love to hand over to Anastasia, maybe to take us through the questions that the people who have raised their hands. Anastasia, maybe if you're there, you can go ahead and you can moderate after this. Maybe we can start with Anita. You can just ask your question. Thank you.
Anita, you can ask your question.
Anita, can you hear us? Maybe as we wait for Anita, maybe there's some network issues. Are you able to hear us? Are you able to unmute? Okay, maybe we can go to.
Yes.
Okay.
Oh, good evening, everyone. So I'm Anita, a student from University of Rwanda doing medical science. So my question was, I was having two questions. The first one was answered. It was all about the patient's pressure to be prescribed antibiotics. So the second question is like, doctor, would you please tell me, is there any kind of antibiotics that are well organized to be prescribed, not just like once medical doctors are not first tried to do the laboratory tests? Because recently I went to the hospital and they prescribed me antibiotics and I was not cured. And I returned back there. They just decided to prescribe me another kind of antibiotics. Is there any antibiotics that are decided to be prescribed before they just do medical checkup of those stuff of gamma staining and whatever? Thank you.
Right, thank you for the question, Anita. And I think what you're describing happens very, very often, where someone comes with a problem to a healthcare provider, they get given antibiotics, the problem does not get better, and they come back and they get given another course of antibiotics. And that's really a problem on the healthcare provider's part, because if they have not seen you responding to an antibiotic, then they need to be thinking of something else. So your question also speaks about, is there any antibiotics we can give without doing certain diagnostic tests? And the answer to that is yes. There are antibiotics that are recommended according to best practice that is based on evidence. So according to often multiple studies, systematic reviews, and meta-analyses, there are evidence-based guidelines that recommend the use of certain antibiotics for certain conditions. So an example of this is would you like to use is a urinary tract infection, where we and the guidelines might vary from country to country based on what research is done and what organisms have grown there. But in South Africa, the most common organism responsible for urinary tract infections is E. coli. And we know that this is usually susceptible to certain antibiotics like ciprofloxacin. So that's often the antibiotic that when someone comes with symptoms that are characteristic of a UTI, we prescribe that without performing any diagnostic testing. Also, in South Africa, I'm not too sure about many other countries, we have what we call a syndromic approach to sexually transmitted infections, where if someone comes with a discharge or if someone comes with an ulcer, we have set groups of antibiotics that we prescribe to cover the organisms that are most likely seen in those conditions. So in that case, again, we're not going to swab the discharge and send it off for any kind of testing. We're not going to do any kind of diagnostic testing. So yes, to answer your question, there are antibiotics that you can give and do give in certain instances for certain suspected conditions, and that is the recommended best practice. That is not the clinician being a poor prescriber of antibiotics. But the big problem is if you have given that recommended treatment for that suspected condition and your patient comes back and they have not improved and you prescribe them antibiotics again, that is a problem. The healthcare providers need to be thinking, what else could be going on? So in the case of a UTI, if you come with classic urinary tract infection symptoms and I give you the standard antibiotics that we give for urinary tract infections and your urinary tract infection does not get better, then it is appropriate to do diagnostic testing, because I'm still sure that you have a urinary tract infection, but obviously you might have an organism that is resistant. So that's the difference. I hope that answers your question.
Anita, does that answer the question? Okay, so probably Anita will respond in the chat. Thank you very much, Dr. Jamie. Let's continue to Obed. Please unmute and ask your question.
Okay, hello.
Yes, hello, you can be heard.
Yeah, thank you. So my name is Michomiza Obed. And before I jump on my question, I would like to say thank you to the doctor for this wonderful presentation. So I would like, it's like my question have been answered throughout the presentation, but I need a specific clarifications. So throughout the presentation, we have saw that this antimicrobial resistance, it's a global issue, but I'm wondering why is it burdening sub-Saharan Africans specifically? So it's like, we have saw that the misuse or irrational use of drugs, antibiotics, usually plays a role in the development of antimicrobial resistance. So, and if you try to look at this, you find that usually sub-Saharan Africans, the people there, anyway, they're not highly using these antibiotics. So usually I'm asking why is it specifically affecting sub-Saharan Africans? And after answering that, I would like to know what do we need to do specifically to tackle these issues. Thank you.
Thank you for that question. Yes, I think that's a very interesting question. And when I saw that data that sub-Saharan Africa has the highest burden, I was surprised and also a bit disappointed, because coming from South Africa, I thought, maybe we were doing a bit better than the rest of the world. But yes, so very, very interesting, very good question. And I was trying to read around it, and from what I could find, it really seems like a multifactorial thing. And it seems to be related to poor legislation. So they're saying that we don't have the appropriate structures or systems in place to actually monitor our antimicrobial use and distribution. And I think, again, it's got to do with maybe diagnostics. So we're not utilizing our diagnostics appropriately, or they're not available. And also it's got to do with the availability of certain antimicrobial agents. So it's very easy for me to look at a lab result and say, okay, this organism is resistant to drugs A, B, and C, and I need to give drug X. But what if my facility does not have drug X or any of the drugs that that organism is susceptible to? And I'm in a rural community that's very far away from another pharmacy or far away from another healthcare facility, or my patient is unable to travel to another area to obtain that antibiotic, or that antibiotic is very expensive, then what do we do? And I think that's another very difficult situation, and I don't entirely have the answer as to what the best thing to do in that case is. But I think a lot of the time then we just give what we have. And I think that's a big problem, is actually having stock of the antimicrobials. And, you know, even if we've now identified the correct antibiotic we're supposed to be using, it doesn't always mean that we have that available. So to answer the question of why sub-Saharan Africa is particularly burdened with antimicrobial resistance, it really is multifactorial. And it's also got a lot to do with our high burden of TB and other infectious diseases. And that also relates to that story that I spoke about, where we were giving that gentleman who had the multi-drug resistant TB multiple courses of amoxicillin when in fact he just needed TB medication. And TB medication is forms of antimicrobials too. So again, multifactorial. Maybe I could even share the article with Daniel. Maybe he can share it to the group on that analysis of the global burden and why sub-Saharan Africa has the highest burden. And in terms of what we can do to try and mitigate that, I think it's just everything that we've mentioned about antimicrobial stewardship. We need to do all of the steps, and we need engagement from government. We need engagement from private sectors as well. Yeah, like I said, it's not something we can combat on our own.
Okay, wow. Thank you very much, Dr. Jimmy. I think we are getting a lot of questions, from your presentation, there's been a lot of thinking through and trying to find out what exactly is the problem and how can we get involved in fixing it. So the next person is Mabula. Please unmute and ask your question. Hello, Mabula, can you hear us? Okay, so let's start off with Colonel. Maybe Mabula will ask his question afterwards. Yes. Oh, he's on. You can go ahead, Mabula, please.
Hello to all. Thank you, Doctor, for the good presentation, which is well understood and also so nice to all of us. I would like to know something from your presentation, especially to the subtopic, which was patient contribution to antimicrobial resistance. You mentioned one point, which was poor preparation of food. So I was thinking myself, if the issue is poor food preparation, it may be if a person prepare well the food, he or she may avoid this issue when it's come to food as a source of antimicrobial resistance. So now I would like to know, taking an example, the food was from agricultural product, meaning it may be maybe vegetables and other things, which maybe by you, for example, animal manure or human manure was used as the fertilizer to fertilize it, and assuming that manure maybe was having mobile genetic element which has got resistance gene. So I was asking, do heat, if food were cooked well, do heat able to inactivate this mobile genetic element that has got genes for genes for resistance? And also, taking an example, the animal, a person consuming animal food product which has got a drug metabolites. Once he or she may take a better cooking or well cooking of food as a precaution to avoid this. So I was asking myself, do heat also able to inactivate these metabolites of the drug that may be in one way or another may subject a person to a situation of gain the resistance of the the normal flora which someone may have as a protective may be subjected to such condition of having resistance to antibiotic. Thank you.
Thanks, Mabula. So, okay, so let's start with the first part of your question. So I think what you were asking was the food preparation and cooking and cleaning of the food, can that kind of deactivate the ability for the bacteria to have that host genetic transfer? And I'm not 100% sure on whether the heat in the cooking actually deactivates that particular mechanism of genetic mutation. But I think more so what it does is it kills the microorganism. So organisms like to live between certain temperatures, just like animals and humans do. And the temperature of cooking is usually, or boiling, or is usually a lot higher than the temperature at which microorganisms like to live. So what's going to happen is at these higher temperatures, the enzymes and the actual constituents of the bacteria are going to not be able to survive. They're not going to be able to sustain life in that heat. So by washing the fresh produce thoroughly, cleaning it with water, salt and water, that gets rid of other organisms, not just microorganisms, but other organisms from the produce. And then cooking things well, like your meat, particularly pork and chicken, that will also help to reduce the bacteria, probably kill all the bacteria. And then the individual who then consumed that meat or produce would then not get that bacteria because it would have been killed through the cooking process. Then with regards to the actual drugs that might be present, or drug metabolites that you're speaking about in the second question, that might be present on our foods, that is a very big concern. And I think it's towards the end of the presentation, I spoke about the One Health perspective, but it didn't really go into much detail. But what that really emphasizes, this One Health approach, is global health and antimicrobial resistance doesn't want to just include patients and medical practitioners, so doctors, nurses, pharmacists that look after humans. They want to include veterinarians. They want to include climate change specialists, agriculturalists, farmers, because they all have an impact on the produce that we create, and they are the experts on insecticide and antimicrobial usage in animals and in plants, which unfortunately I do not have much knowledge on at all. But I think your question emphasizes the need to utilize those allies as well, that it's not just a human health issue, it's a world health issue. We need to have experts involved in the care of animals, in the production of our food, because these contribute to antimicrobial resistance. It's not just human factors. So when you speak about whether the drug metabolite would actually be inactivated by the cooking process, if I'm being honest, I do not know for certain whether it is inactivated by the cooking processes, but that's definitely something that the area of agriculture and antibiotic use within our animal products, that's a really significant contributor to antimicrobial resistance. Not one that I have too much knowledge on, but it is a very rapidly growing field. So I think it is, if anyone is interested, there is a lot of information out there on it. So I'm sorry that I couldn't really answer the second part of your question, but there is a lot of information available on those kind of topics as well.
Thank you very much, Dr. Jamie. So before we continue, I'd like to ask if you have, I know we are past our time. I'm just inquiring if you had a little more time for a few more questions, or we could gather these questions and send them to you, depending on if you have time.
Yes, sure. So if there are more questions, I'd be happy to. You can gather them, send them to me, and I can respond in like a written form and reply. I'd be happy to do that. And then I can also include some of the additional maybe documents and articles that I think might be worth reading if anyone's interested.
Okay, thank you so much, Dr. Jamie. Colonel, I'm going to request that you write your question in the chat box, and then I will just put them in a group Word document, and then we'll have them passed on. So probably at this point, allow me to thank you once again, Dr. Jamie, for taking off time and sharing with us what you know. And also actually, I'm sharing with us your experiences, because it's one thing to say something and it's one thing to have experienced it and be willing to share. I don't know if Colonel has heard me, but I think, yeah, the question will be sorted. Okay, so with that, I'd like to thank everyone else for attending. These are important sessions, and I think the more we go through these sessions, for example, this session, I think the number of questions that popped up and the number of thanks that you have received, Dr. Jamie, just show that there's a lot more to learn. And I am glad to see that the ambassadors are willing and happy to learn. So at this point in time, I'd like to say thank you, everyone. The session has ended. You may leave at will. Yes.
Thank you, everyone.